Well, we're going to go ahead and get things kicked off. Welcome to DocNation's monthly edition of talking about going behind the curtain with hospital administration. We have a special guest tonight, Gary Stone. It's good to see you again, Gary.
Good to see you.
Thank you, Gary.
It's great to be here. Anthony and I are founders and on the executive team of DocNation. We've been pumping out information every month to give you the inside scoop on what's going on within the industry and helping you join a team that is going to be able to go to bat for you to help you have the representation that you need to make change, to make a difference in your workplace. And so super excited to have Gary on board. He has a background inside the system. So we're going to have the ability to have him share what it was like to work in various roles and have a different perspective on the other side of the table with regard to hiring physicians, retaining physicians, losing physicians, the whole perspective of the machine, the establishment. And so we'll dig into that. So Gary, would you mind starting off with sharing some background for our group?
Sure. Right. My name is Gary Stone, and I actually started my career in nursing. So I'm a registered nurse, went on for advanced practice, and through kind of just different experiences ended up in administration, probably very early in my career. So I became the director of intensive medicine, for example, like at the age of 27. So I do feel like a clinician first and foremost, but if you were to look at my background, I have most of my career is in leadership and administration. And so so that first role of intensive medicine included the intensive care unit and the emergency department and trauma. And then as I advanced in my career, I moved into hospital operational roles, chief operating officer or vice president in a large system, where I built practices both in a hospital setting, so inpatient practices, like I built an intensivist team, a hospitalist team, employed them. I also worked, in developing outpatient practices in oncology, sleep medicine, and so I understand the administrative wheels that turn in both hospital physician practice and outpatient clinic practice. I've also had the distinct pleasure, which is, I say that kind of with tongue in cheek, of mergers and bringing private practices into an employment model, which is very challenging, but learned a lot about that. So hiring physicians, compensation models, and I've really found an interest personally about how to ensure that we are leveraging the top skills of providers, right? So that they're practicing at the top of their license in a way that creates value for them. And I want to do that, and have tried to do that in my career through innovation, disruptive innovation. I don't want to just innovate. I want to be disruptive in the way that we innovate.
Well,
Awesome.
I have to thank you, Gary, for coming on, because I asked a bunch of current hospital administrators to come on, and I got a hard no across the line. Basically, understandably, they answered to a boss as well, but I'm telling them, like, we really have to talk about this situation between physicians and hospitals, or physicians and insurance companies. And we need to know the other side of the coin. So I'm really happy you're on. I'm really happy. Hopefully, as I always tell our audience, ask your questions. We will try to get to all of them. If we don't, we can answer them afterwards as well. We already had one question roll in, which is great. We will get to that in a little bit. But I'm excited because a lot of what DocNation has to do is help the physician in that negotiation with the administration and with the hospital. So thank you for coming on.
My pleasure. Thank you for inviting me.
So Gary, if we pull back the curtain and go on the inside, what are some of the things that we're going to find that would surprise us? We know there's problems. We know there's issues. We know that compensation is so far off track, and the retention issues and there's so many things we could talk about, but what are some of the things that would surprise us that we would see as providers?
Boy, I don't know that anything necessarily would be super surprising. I can tell you that that the the administrators and also the insurance providers also have constraints and frustrations as well. And so some of the issues really are tied to the way that our health system works in the country. But when it comes to hospitals, there's a really big difference between the hospital employed physician, like
Mhm.
that they're hospital based versus when they're in an outpatient clinic setting. And I think the biggest challenge, and I don't know if this will be surprising, but what always became a challenge for me is justifying an outpatient practice um, with the kinds of reimbursements that is available. Especially if you're dealing with, a population in a community that may have an indigent community that's either on Medicaid or uninsured. And so what the clinic's trying to deal with in an outpatient setting is, how do we make money to pay the overhead, to pay the staff, to pay the physicians, and keep the lights on with the payer mix that we have. And in some hospital systems, the shareholders do have a big role to play if they're a for-profit, right? So they really just do care about, making money for the corporation, especially if they're publicly
Mhm.
traded. And we
Yeah.
can talk about publicly traded and what that really means in the healthcare systems versus not-for-profits. Now, it doesn't mean that a not-for-profit doesn't want to make money, but not-for-profits have more of a tendency to not have such huge pressures from markets. They can move internally to deal with losses, but at the end of the day, what happens is a juggernaut of an organization may not be experiencing losses over in the hospital proceduralist area. So they might be, in an orthopedic hospital making plenty of money. And that same system might have a clinic over in another part of the state with a poor payer mix.
Mhm.
And those two hands don't often talk. And therefore, you have all this money and revenue coming through, but you have the shortfall down here in this other clinic, but you can't treat those physicians differently and the allied health professionals differently just because they don't have a strong payer mix. So the problem really comes down to our financial incentives in the healthcare system are not well aligned with physicians, with providers, and really the end goal that we have, which is taking care of patients. Because ultimately the incentives are driven by RVUs, that really are like cogs in a wheel.
Yeah, I think
Can
that's
you?
one thing that's a sticking point in a lot of physicians that are showing me their contracts is the RVU payment or the RVU model. And I feel most hospitals are going to that model because it's very easy to kind of manipulate a person with the RVU number. I think it's also very easy for CMS and insurance companies to manipulate the RVU number then. So after you get, let's say you get $50 per RVU or whatever it is, I'm just using that number. No one out there think that, I don't think that's fair, but just use that number. And then, you negotiated for a good number for your RVU. And then all of a sudden January 1st rolls around and they cut your RVU for a consult by, 10, 15%. I think that RVU model is a good way to keep the physicians kind of in the dark about what their compensation really is and really should be and what their worth is. What is your take on the RVU model for the hospital systems?
Well, I think for hospital systems and for clinics, the RVU model is very antiquated. I think, and the and I towards the so end of my career, I have had the opportunity to retire, so that's been nice for me. But anyway, that's not the point. But toward the end of my career, what I really was trying to focus our organization on is disruptive innovation, which includes compensation for physicians and not basing compensation at all based on RVUs. Because eventually RVUs do become arbitrary. You can say that, you could do some comparative models and look at, across the nation, what are physician specialties experiencing in, RVU productivity, and look at the rate per RVU for a specialty, and also like how many RVUs do we typically see with a productive physician in a year. But you're right, and I don't know that I would use the word manipulative, and maybe it's because I'm thinking as an administrator. I don't know that I necessarily manipulated the RVUs so that I could save money, but I did know how to manipulate the RVUs so that I could ensure that I was like not going to lose a physician that I really couldn't afford losing. So what that tells you is that yes, there is a way to kind of shape the RVU to get to the compensation level that you need. And oftentimes what happens is the healthcare organization is kind of heavily burdened with different laws that might exist in the United States that cause larger organizations to worry about fair compensation and whether we are compensating like more than we need to or should with a specific specialty than others. So you have to find all these benchmarks, which eventually starts to become arbitrary. So what I had proposed, and it was really liked, was to completely abolish RVUs and really to just focus on take money off the table, so that you as a physician are not going into your practice wondering, am I getting enough RVUs this week? That's awful. Like, or this month. Like you should be able to go into your practice, and if you've got a patient that needs extra attention, especially like if you're in psychiatry, neurology, oncology, and that patient takes an hour and a half. What I don't want is a physician thinking to themselves, this patient is not going to generate the RVUs that I need. I'm losing money hand over fist, and I'm going to get in trouble. I'm going to get, the administrator is going to come and tell me my RVUs are low, but I'm doing the right thing for patients. And so I want that off the table. And what really, and I don't know if this is a negotiating point, it'd be great if physicians, maybe the way that this changes, because I could not get this changed internally, maybe the way we change it is physicians across the country start saying, in our contracts, we want a compensation that is fair, equitable, and salaried, not based on productivity. And then we want to be bonused, incentivized above and beyond that based upon quality, patient satisfaction, access, or whatever metrics the organization and the physician agree to, right? So that it isn't like, again, a hammer, but really a carrot.
Yeah.
So if I were going into practice and I had the ability to like negotiate with a hospital organization or an integrated healthcare system, I would say, look, I don't want to practice on RVUs. I want to be compensated based up like your CEO's compensated. Not that you'd be paid exactly the same, but
Sure.
they're not paid. That's like, to me, it's like saying to your chief financial officer, you need to clock your hours and we'll pay you hourly. That's what we're doing to highly professional people. And I think it's out of date and should go away.
Can you speak to what you think is transparent versus what's non-transparent when it comes to the revenue being generated and where all the revenue lines are for each provider?
Yeah, I think that where I came from, it was we could be transparent, and we tried to be. I think the problem is it's not very easy for anyone to see, just because of how reimbursement works with insurance companies and Medicare, commercial payers, et cetera. So, I mean, we can see like commercial payers will pay more for these RVUs. And we will share those. Where I came from anyway, we would share that with information with physicians. The problem is, though, is that what that does, and Some organizations may not do that, but even if you do that, have that level of transparency, what does that do? It could inadvertently incentivize the provider to go after more lucrative RVUs. I saw this in oncology all the time. They knew exactly the kind of RVUs they would get if they did an infusion every week versus an infusion that could just be done monthly. But they knew what those RVUs were. And so they were attracted to patients that were paying more. Because then they won't necessarily get paid more money, but their RVUs go up. And so so then all of a sudden, the patients that don't have great RVUs, docs don't want to see them. And you end up with this weird, competition between physicians.
So I guess I'm thinking about that question in terms of overhead, and there's this tug of war between what a doctor is producing, their billings, their collections, the revenue that's coming in, tracking the direct revenue that they're associated with. There's all these indirect revenue sources as well on top of that. So I would imagine that's harder to track than the direct revenue lines. But from an overhead perspective, what are you seeing from, because we were talking about this beforehand, and
I think your question's going where one of my questions is yeah.
Yeah, the alignment of the system or the machine or the institution is not aligned with the physician. There's a lack of alignment.
And I'll add to that. Why? So there's only X amount of money in the pot. We agree with that. If we're just talking straight money, and I believe RV is a way to keep that doctor's pie piece exactly where they want it. We know it's 9% of the whole pie. I think an RV model is an easy way to keep it there, at least keep it kind of bouncing back and forth. My question is, one, you might have a better answer to this than I know, is why are there so many administrators per physician? The numbers out there reported, you can Google it right now, administrators per healthcare provider is 14-1. If we're talking about bloat, if we're talking about, I hate when hospitals say they're losing money. It's like, you're not losing money, you have too much overhead. It's not the physicians, it's not that are causing the money. Yeah. In your time working, because this bloat in administration has happened since the late 80s, I'd say early 90s, and it's going straight up. We've all seen that graph. Why do you think that's occurred? What do you think has driven that?
Boy, that's a good question. I think that the administrative work that happens, this really is different between an outpatient clinic setting versus a large integrated system. If it's a large integrated system where a system owns a medical group, which are outpatient practice physicians, owns hospitals, which are inpatient physicians, they also own a health plan. There is significant administrative burden across the organization to.
Whose fault is that? Insurance companies making it harder? Is it the government making it harder, or is it the hospital system itself making it harder to get that paperwork, that administrative work done? It doesn't help the patient, right?
I would say it's all of the above. A part of it is it really is the way that the system of healthcare works in the United States. Now, I'm not saying that it's necessarily much easier in other countries, but you can see where the administrative burden may not be as difficult because you don't have so many independent practices. So let me give you an example. In an integrated healthcare system, you may have the system owning the hospitals, they may have an insurance arm, they may have some clinics, but they also will oftentimes employ a independent group of physicians to manage the ER. So you have an ER group that is independent, an anesthesia group that is independent, laboratoricians that manage the lab, but they are all independent. So they have their own contracts they're negotiating with the system, and they, in a way, collectively bargain. If you're a whole bunch of pathologists and you say, we are a group of pathologists, you're going to negotiate with the group, I'll tell you, they'll make a hell of a lot more money than you by yourself. trying to negotiate for a single employment contract.
This is the concept behind DocNation, trying to
Right.
make
It's collective, but
Yeah.
but that so I mean, I agree that like there can be too much overhead, but I also, but I think part of the reason for that is due to the complexity of our systems. And I've gone back and forth with an organization where we have said, look, physicians are tired of MBA administrators, so we're going to go for a model where we are mostly physician administrators. And there's pros and cons to that as well. There are challenges with that, and I'll tell you what I believe pretty strongly is that what really is the problem that we should be focused on are the processes that are associated with aligning the correct incentives. So if anyone's compensation, including the organization, if the organization is paid really well, if they do a whole bunch of labs, but they are not reimbursed well for psychiatry, where do you think the organization, whether you're a physician administrator or an MBA administrator, where do you think your eyes are going to wander to? And it's because the way that the payment models are set up. So there are ways, though, that healthcare organizations can transcend these outward pressures. So maybe Medicare and Medicaid do not pay well or Medicare pays well, but Medicaid, sometimes Medicare pays well, but Medicaid, for example, in the ER setting. So a large system has the cash backing to cover the shortfall in these areas, and they should. I agree with you too, Anthony, where it always frustrated me as administrator when a chief financial officer would come and say, we're losing money. And I know full well, yeah, we're losing money, but I also know what's in the treasury, right? I also know that there's $10 billion, worth, or I know what our revenue is. But oftentimes those pressures are coming from a couple of different sources. If you're for profit, it's absolutely coming from shareholders. And that, whether you like capitalism or not, one of the foils of capitalism is that the interests of the shareholders do not trickle down. So we want to say that trickle down economics works, but it doesn't in this setting, because the only people that matter are the shareholders. And when they're unhappy, you better be cutting FTEs. And they may be unhappy not because you're losing money, but because you said you'd make this much money, but you only made this much money.
Yeah.
As soon as you go public, that's what matters. So to the hospital, to the system, it's like, we're losing money. No, the shareholders are upset because we didn't gain as much as we said we'd gain. And we have to correct that for some reason. So that's another pressure that I think we have to be really careful about thinking through as we kind of move into the 21st century and consider, like, again, where are incentives aligned? And I don't know how well that translates to a physician who's negotiating in our current system, but I think what you're negotiating, it's helpful for you to be educated on what pressures are happening to the administrators, because it's not necessarily nefarious. It really is pressures from misaligned incentives.
So
Yeah,
can you talk about those incentives? Jumping in real quick, the incentives that you're talking about, are you talking about like all levels of providers, all healthcare practitioners, and how they're incentivized, or are you talking about how they're getting reimbursed from outside sources and the incentives that the establishment has coming in? Like, can you nail down the difference between those two?
So if you are a hospital system and you get paid more for labs than you do for an ER visit, your incentives are now aligned to do labs, not to run an ER. If you are a for-profit organization, your incentives are to please the shareholders, not so that you're aligned with the shareholders' interests, not necessarily the patients. If you are a physician and you are aware that you are going to generate higher RVU volumes for a infusion, and a certain type of code, a CPT code, then you're going to be, whether you could think you're the most altruistic person in the world and that you only want to care about patients, but when you know in your mind, I've got to make money either as the administrator, as the physician, or as the shareholders, they're all in the alignment of those incentives are all misshapen and misguided, and none of them are centered around the patient.
Yeah. All right.
And so you're saying that the executives they've decided to reward certain things more than others. It's the leadership in the institution, or are you saying where the money's coming from on the outside?
It's the way the system is rewarding, and rewarding is probably not the best word, but it's the way the system's paying on CPT codes.
Okay.
So we got some good questions here that I want to dive into a few of them. I'm just going to ask them to you, Gary. And the first one is wanted to make sure to ask, has anyone ever heard of hospitals not wanting to pay doctors above the 90% in total cash compensation? I don't really know what
That's a great question.
Yeah.
Boy, that's a smart question. So that's an astute question, because what that tells me is that person understands another pressure. So, Justin, you're asking about these different pressures, and I because I do have the background, and I did want to do the right thing, and I wasn't thinking to myself, how can I lace my pockets? Even though that's still on my mind, I want to get my incentive, right? But if my incentive's not the same as Anthony's, then we're going to be misaligned. So I just want to put that caveat on here, because this is another example of a regulatory body that may be putting pressure, and it may not even be a regulatory body. It may just be historical precedent that's happened in court cases where an institution can get into trouble with different laws, Stark laws, et cetera, if a physician is paid beyond the 90th percentile in market research studies. And so many organizations, like the one that I came from, will stay conservative, and they'll start with a compensation at the 50th percentile. And that's where physicians will get really dissatisfied, because they'll say, well, the 50th percentile, but I'm producing this much work, or I can't live on that, or my colleagues elsewhere are making much more than that. So many organizations will say, we're going to cap at the 75th percentile across, the markets, labor market studies. And going to the 90th percentile, oftentimes it did happen a couple times in my organization, but it really takes like an act of God to approve, a compensation at or above the 90th percentile.
I've even heard people be told, especially surgeons, to slow down because they're going to hit their bonus is going to be too high and put them outside the 90th percentile.
Right.
I've actually seen it where a good physician is told that they're doing too much work and they need to slow down and do less surgeries or less procedures because they're going to go outside that 90th percentile. Which makes no sense.
What's other than trying to control labor costs, what is the justification, the legitimate justification that somebody's producing because they're efficient, because they have the schedule that they do? If they're producing in the market the volume, what is the justification to have them say that we're going to try to put a ceiling on you?
Because there are physician compensation laws, and there are different regulatory. Some of them are regulatory, and some of them are actually laws, like Stark laws. So it's not necessarily because the organization wants to save money, right? It's because the organization doesn't want to have some kind of a fair market value flag and then be audited.
Yeah. No, I think, and that's part of what DocNation. So a lot of people always ask me, well, what are you doing at DocNation? A lot of our focus is to help negotiate contracts, not just compensation, but other things in contract. But the other thing is to build a cohort of physicians We have, you go to DocNation.com, you join the nation. We don't have the yearly membership fee up yet, but we will. And what that's going to go to, and we're actually in the talks right now, is to hire lobbyists, because everyone else has lobbyists. If you look, hospitals have lobbyists, ASCs have lobbyists, short-term care has lobbyists, long-term care has lobbyists, physicians have nothing. And a lot of these laws are made to keep us in this box. I think someone said really well here that if you keep the physician's salary low, the 90th percentile never grows. I agree. If everyone's making it the 90th percentile, all of a sudden it's the 50th percentile, right?
Well, and some of these laws though actually came into being, honestly, because like there's the physician self-referral, which is stark, right? Anti-kickback laws, private procurement statute, False Claims Act, civil monetary penalties laws, healthcare fraud statute. Some of these really did come into play because there were physicians that were not practicing ethically. Now, not like rampant, but
it wasn't rampant. If you look at it, it was the early 90s.
Self-referring or something, you know.
I mean, I think there's just as many people breaking Stark violations now as there were then. Just now they have a way to.
Yeah, but because that law is in place, what happens is an organization that is conservative and doesn't want an investigation will overcorrect.
It's killing the physician. I mean, I think Leonard, or sorry if I got your name wrong, but Stark law is all written by attorneys. I mean, it's 100% true.
It is. That's so true.
A lot of what DocNation is trying to do is one thing you mentioned earlier too, and I didn't want to interrupt you. We're going to push to say that there has to be a physician in every C-suite of a hospital. Sorry, like you don't get to run the game without the physicians. You know, one if people have probably heard me say this in other webinars, the physicians are the players, and in the early 70s and 80s, you know, the players in the NFL and the NBA were getting treated very poorly and did not make much of the pie. And then they got representation. They started the Players Association, which was their union. And now look at it. Without the players, there is no game. Without the physicians, there is no game. We don't need 14 administrators. We don't need health insurance to do medicine. To do medicine,
right? Without
the health insurance company, there's still.
I agree.
Without the hospital, there's still medicine. Without the physician, there's no medicine. You know, and that's the mindset I like to set forth in these webinars. Is, you know, we have a hashtag that we use a lot in a lot of our posts called Know Your Value. And one thing, while I have you on, I definitely want to ask this question, because part of your value, people think their value is just boom, the RVUs I create, and Justin kind of came up with the ancillaries you create. But your values also, and I have this question for you, and I don't really know the answer. I know there is something to it. What is your cost of replacement? I think a lot of physicians are afraid that if we raise a stink, we're going to be replaced very quickly. For you, you'd rather keep a physician
every time
than get a new physician, right?
Yeah,
and
I mean,
it's need to know that. So if you can go through
$500,000 to $1 million.
Yeah.
But it's not just that. It's the referral patterns. Now, if you have a physician, there's 5% of the time I've had a physician that really I didn't want, primarily because patients hated that physician. So they didn't want to see them. So obviously those are situations where you really wouldn't want to keep the physician on board. But otherwise, physicians are the light. Think of it this is how I always think about it is, well, the customers are your patients, and to the customers, the thing that they care about in healthcare is their personal connection with their physician. So what you lose, what's so important to understand is what you lose when you lose a physician is a referral pattern. You lose your brand. The physician is your brand. It's your market. It's what people. It's word of mouth.
Hospitals don't think that way though. They think the hospital is the brand, and the physicians are just lucky to be there.
No, I know. Well, then that's kind of some Kool-Aid that they're asking you to drink. Yeah. Because I know for sure I can have the best brand as a healthcare organization, but my patients, my customers are going to follow their doc.
Exactly.
That's why sometimes we do these non-compete, things in the contracts. I just wanted to say one thing about non-competes. They are stupid and never really enforceable. So they are kind of a fake hammer. I can tell you every time that I've thought about them or had people want to negotiate them out, what I always tell my legal team was, I don't want a non-compete clause because I can't enforce it anyway. Like,
Yeah.
and they'll agree, like our attorneys will say, yeah, but we still have to do something. And I'm like, why are we, it's such a fake threat. I promise you, it is very difficult for a healthcare organization to actually enact a non-compete.
How many,
It's
so let's
funny.
talk about that. Let's talk
Yeah.
about that. How many physicians in your experience have you seen leave an institution, and just some, general number, and what percentage of them did the employer really want to take the time to go try to enforce it?
So it happened one time in my career. This is, a 30-year career. But it was the institution that I recruited a physician from. And I told the physician that I recruited, because he was fantastic, and I wanted his patient referral pattern, right?
Yeah.
So
Yeah.
I know how to entice him. And I said, look, they can cut, let's see if they'll go after you. And they did, but they could never really enforce it. It was a threat. But the problem with non-competes, and the reason they're not really enforceable, is how do you prove that you're harming the organization when there's such a shortage of physicians?
Yep.
You're not saturating, the market's not saturated enough where you could actually prove in a court of law that somehow a patient group has been lost. Like, I guarantee you there are plenty more patients for that organization that this physician left. They wouldn't even notice. Maybe they'd noticed it for 2 months.
So are
That's
you
why
saying
they're
like
not.
one out of 100, one of 1,000, one out of 2,000? I mean, what do you suppose the ratio is of this actually happening? Because we
Well,
talked to so many that are
actually it happening. So they went after him, but it didn't hold up in court. He won.
Yeah.
So it's almost a 1% chance that it would actually get enforced, and the organization would win it. It is unheard of in our country. There's too much of a shortage of physicians.
And hopefully the next 3 months, someone on here said, if FCC abolishes non-competes, one thing with the FCC going on with the FCC with the non-competes is that they say it affects 15% of Americans. You look at physicians, and I looked up the number, 95% of physicians are under a non-compete. So that's another spot where they really hold our head to the fire. Is 15% of the general population in America is under non-competes. 95% of physicians are under non-competes.
Yeah. I've never been under a non-compete as an administrator, but I can certainly compete.
The reason they keep us under non-competes is because we do a great job at this hospital. This hospital says, well, we're not giving you any more money. Why can't I just go next door, work at this hospital, and ask for 20% raise? Well, the way our non-competes work is we have to move our whole family and our whole lives and lose all our patients that love us just in order to get
that's right.
We deserve.
And they're not, and non-competes are bad for patients.
Yeah, extremely bad.
I would never. So if you can, if you're bold enough to negotiate these contracts, I would always say, no non-compete for me. I'm not coming if you can't. If you have to have that in there.
Are very good at getting those non-competes. Even people out there, if you have a non-compete, everything's negotiable. Even if you have a contract, it is negotiable right now. You don't have to be up for a new contract. You can walk into the administrator's office and you can negotiate. The negotiators we have at DocNation can help.
Anthony, I really get this vision. I want to just tell you. So I'm just thinking to myself, what if this happened to me and I'm an administrator and I've got a physician?
My last question was, DocNation walks in, you're sitting there, you're expecting Dr. Smith to walk. You give Dr. Smith his contract and he walks out and says, okay, I'll be back tomorrow and we'll look at it. You never see Dr. Smith again. You see DocNation's attorney and negotiator walk in. What is your reaction?
I'm not okay. To be honest, because I also have it. If I'm in a large institution, I've also got attorneys.
Yeah.
And my attorneys are going to tell me, we've got to have a non-compete. You just have to have it, right? They can't, even though it's unenforceable, but yada yada. So I would say, okay, DocNation, we're going to have a non-compete, and DocNation would say to me, well, then you can't hire this physician. I would say, I'll go recruit another physician then. Now, this is if I'm hiring, right? And there are physicians for me to go out and hire. Yeah. I'll tell you what will hurt me though. If you want to hurt me, and maybe that's not the right way to say that, but to really negotiate with negotiating power, it would be if every time I'm recruiting a physician,
Yep,
I'm hearing them say,
yep,
we are not accepting a non-compete. So it's not a
exactly.
one-off, but it's Anthony,
Boom.
it's Sheila, it's
Yep,
Justin. And if I have that happen 5 times, I'm gonna tell the organization we can't hire anyone because
yep,
we're insisting on a non-compete. That's the power.
This is how unions work. I mean, a lot of people don't like the U word. I call it union, call it a players association, call it whatever you want. 3 people have said in the chat, is it time to unionize? This is what DocNation is. It's saying, hey, we're all gonna fight for the greater good. And we're not trying. A lot of people that are naysayers for DocNation say, well, you're gonna ruin healthcare. I don't believe so. I mean, you look at where the money in healthcare is lying. United Healthcare made $18 billion last year. I'm pretty sure they could take a little haircut. Like you said, Gary, why do they make $18 billion? Because they're publicly traded and the shareholders want $18 billion a year. They're working on a 14% margin right now, which is amazing. For perspective, Walmart works on a 2.4% margin.
Right.
So there's some haircut there that can easily go to the physician side of the pie. That's not going to happen though, unless physicians start pulling together in the same direction. And I see it all the time on LinkedIn. I see it all the time on Facebook group chats. Physicians have a very, very tough time of pulling in the right direction. We fight each other.
Yes,
which
that's
is
true.
a big problem.
Yes, it's true.
That's what, to me, everyone behind the curtain wants to see, is us beating each other up. I say all the time, don't get in arguments on LinkedIn, because guess who sees it? Hospital administrators see it. Insurance companies see it. Everyone sees it that's trying to keep the physician down. Direct message someone if you have a problem with a procedure they did or something along those lines. But this is what DocNation is all about. And you don't even need to join DocNation. You don't have to have, you might even love the spot you're in. You might love the contract you have. But I think as physicians, we owe it to ourselves to all band together in one group and unionize. And a lot of small groups have tried this, maybe one specialty. No one's tried it yet across the whole physician group. And I'm lucky enough to have some partners that have some really good contacts to try to get a good cohort. And Justin, we've talked about this. What is the number we think we need to get to really start pushing our weight around? If you get 2,000 doctors, 1,000 to 2,000 doctors beating the same drum, running in the same direction, things are going to change. Ears are going to light up for sure. And then you just get some lobbyists in DC that we throw some mone behind. Unfortunately, that's the way the world works, guys. We know this. We've been taken advantage of by it because we don't have the lobbyists. I wish we didn't have to. I hope no one out there is a lobbyist. A lot of my best friends are. I tell them I wish you didn't have a job. But that's what we need to do, and we need to advocate. We need to advocate for physicians. We need to find a way to band together. There's some really great questions here, Justin. Do you want me to dive into a few more for Gary while we have him on? I mean, we're at the 45-minute mark, which we usually like to try to cut it, but I don't think we've lost a single attendee since we started. So
no, we keep on gaining, actually.
I mean, if we want to go 10 more minutes, Gary, are you okay with that?
Sorry, I was on mute. I'm totally okay with it. I actually I can see the questions. They're great questions.
Yeah.
They're smart.
How do we recruit more docs to join? I think that's a great question. Lauren, you'll see Lauren in the question and answers posting some links. She's one of our administrators that helps us out. And basically join the LinkedIn, join the Facebook, but join the nation. Go to docnation.com, join the nation, and share that link with everyone. I think, Lauren, if you could put that link up again, the join the nation link, share that link with everyone. That's where we're collecting, and we're not going to sell your emails or anything like that. We're just collecting the names, and we're building that cohort of physicians to see if, hey, we're going to go after some lobbyists, and we're going to say, this is what we want to do. We want to pull in the right direction. The other thing we're going to do is once we already have 250 doctors that have clicked that button and joined the nation and signed up. We want to have quarterly meetings as well. So when we have those quarterly meetings with the whole group, everyone will have a say. There won't be panelists. Everyone will have a say. We'll try to get things in an orderly manner. We'll have, a way to go about it. But that's when you can invite your friends too as well. And the other way to get them to log on to one of these webinars and see what we're all about. We do it, the fourth Tuesday or the third Tuesday of every month. Well, you'll see our stuff on LinkedIn. You'll see it on Facebook. So this is what we need. We need to all start pulling in the right direction. But let's get some more questions for Gary here. Mr. Stone, what if you have to do with 5 docs in the same practice and not one? Yeah. So if you have to deal with 5 docs in the same practice, the negotiation is going to be different, right?
Well, Yeah. Uh, So ask that question one more time about the,
I think they're asking, if you have 5 docs all negotiating at the same time, except for just instead of just one. Like if the whole radiation oncology group comes to you and says, we're sick of our contracts, does that help them? Or
yeah, that's more powerful. You
Yeah.
want the whole group to say, yeah, it's much more powerful as the group. So the group of med oncs, for example, if there's 10 med oncs that say, we don't want to be on an RVU model anymore. Our patients stay too long, and it creates a misaligned incentive. So we want to be compensated, and here's what the compensation should look like. And then that's much more powerful.
There's another great question here. I don't know if you saw this, Gary, when you were in administrative, but thoughts about mid-levels and scope creep. So I'm seeing this in New York, and whoever put this up here too I saw it in New York. Someone actually asked me direct message over LinkedIn. I almost put it out there, but I have a big thing. If they direct message me, they didn't want it to be public, so I don't post it. But they asked me, would I accept PAs doing all my injections and kyphoplasties and that kind of stuff while I wasn't in the office? And I said, absolutely not. Scope creep. Do you think we're seeing this push towards NPs replacing doctors because they're cheaper? What do you think about this? Do you see it at all in your practice or in your?
Yeah, this is very, very debatable. So the reality is, if we're talking about aligned incentives, a physician billing a CPT code for an RVU is always going to be higher than a mid-level. So it's actually would not make sense to use mid-levels unless you were in a situation where the RVUs are not great, and you want to extend a physician in like a hospital setting. So here's an example. So is it going to be more productive for an oncologist to say in the outpatient setting rather than making rounds in the hospital? Or does your hospitalist group really need all physicians when, if they're salaried, you could use nurse practitioners? Nurses are already trained really well in the inpatient setting. But I don't think that I think that a trend to move to mid levels is going to sway back and forth with wind. It's never gonna, there's not a trend that's going to go one direction, because as soon as you start doing this with mid levels, there's a recognition that the reimbursement's not as good. You also have scope creep. It'll swing the other way. So I would not worry too much about the mid-level piece. Just recognize where mid-levels can be helpful to you as to extend your practice.
That goes against the incentives, essentially, is what you're saying, because it does not help them financially to go that direction.
It depends on
for
the
revenue,
setting.
for top line revenue.
Yeah.
I think someone put it here really well. Mid-levels get 85% of what physician bills, but are about half to a third of the cost of the doctor. And I think the math that a lot of these hospital systems are doing are saying, go to the mid-level, don't deal with the physician anymore. And to me, it's insulting, first of all. That's where, if I was a physician, I'd walk out of that hospital. And that's where DocNation could help too, and plan something like that. Cheap care is bad care. I 100% agree with that too. That this is the kind of stuff. I'm glad I'm not in New York anymore. I'm glad I'm down in Florida. I think we'll be the last card to fall, but it's already happening. So it's not if, it's when, and it's happening quickly.
Yeah,
Did you see the comments about the unionizing and being able to negotiate hundreds of contracts at once?
Yeah, Michael.
That's what DocNation. That's why we built this.
So Mike, I think Mike Caner, or the you're with National Union of Hospital and Healthcare Employees. Thank you for reaching out. We'll probably reach out to you on the side. We are looking. We're actually, who we actually are looking to partner with too is the residents that just unionized. I think everyone saw that in Wall Street Journal. I might be wrong. Might be just making up. You don't get newspapers.
No, they've been around. They're expanding. That's that group that's been
yeah
listening for a while.
So we want to have partnerships with people that are like-minded in this endeavor, because it's going to take a big push to kind of get the gorilla off the back of physicians. And I think it's more than just gorilla. I call it a leech. They see smart people that are altruistic, that aren't very good at business. And listen, I know a lot of good doctors that are good at business, and I have a lot of friends that are good at business, that are just businessmen, and none of the doctors are better than the businessmen. None of them. I'm sorry. Even the worst businessman friend I have is better than the best businessman I know. And they see us as a way to leech off of us. And you know why? Because we took the Hippocratic Oath. Because we are altruistic. We wouldn't have went into medicine if we weren't. We were all smart enough to go to be lawyers. We're all smart enough to go work on Wall Street. No one failed into MD school, right? No one's like, oh, I tried to become a lawyer and I settled for medical school. But that really is where we get taken advantage of. And I'm not asking doctors to stand up and really take the bullets either. I'm just saying let a bunch of, we'll get lawyers on our side. We'll start just turning the tables with the same way they turn the tables on us. Our first webinar was about physicians striking. Do we ever need to strike? I hope we don't have to, but if we did, I think it would last 15 minutes. I really do. I think if every physician walked out of a hospital, it'd be 15 minits before they'd be like, whoa, we're sorry. And we'd probably go back 30 years to where physicians are back in charge. So it's, and these are pipe dreams, like, don't take those numbers seriously. I just think physicians have way more power. We don't know our value. We have way more value than we think we do. And we won't be the bad guys. That's another thing I hear all the time. And Justin, I think you hear this sometimes. And Gary, I'd love to hear your input on this. I think a lot of physicians think if they speak up, if they make a stink, if they get on the front page of CNN or Fox News because they're upset about contracts or non-competes, they'll look like the bad people in the eyes of the patient. I don't think that'll happen. They'll probably try to paint physicians in a bad light, but I really don't think that'll happen. And I think most patients would be on the side of the physician. What do you think, Gary?
Yeah, I think that for sure, the patients are going to support their provider. That's who they really are connected to. And I'll say this over and over again, the real brand is the physician. It's your face, it's your personality, it's your touch, right? All the things that you do to make the patient feel comfortable. That's the connection. And so you do have a ton of power. And I get it. Like I saw some of these comments, if you negotiated as a big group, maybe you're a group of 10 medical oncologists, and you say, hey, we don't want to non-compete anymore in our contract. And do those 10 physicians, first of all, do they all feel secure in knowing that they're not going to get terminated, right? That they're not going to lose their jobs. There's some fear there, not realizing that, no, that you're not. In fact, you could actually say, if you don't do this, we're leaving, all 10 of us, and starting our own competing practice. Go ahead and try to, go after us with a non-compete when 10 of us have left.
Well, I think you saw CMS cuts of 4.5% to the pro fee and up 4.5% to the facility fee on January 1st. It makes that even harder, right? It makes that they don't want private practices anymore. Whoever they is, you guys can figure that out. Private practice, you kind of touched this at the very beginning, Gary. Private practice have been gobbled up for the last 20 years. I think orthopedics and maybe some cardiology places are the last ones standing, just because they can still make, that kind of revenue and keep the lights on themselves. They want the physician as an employee in the hospital, and they want to keep their thumb on top of it. And if you can't look at the last 20 years and see that happening, and believe me, if that's what they want, it's not good for the physician. So I've heard a lot of people, they want to break away and they just can't do it. Yeah.
One of the things that maybe as we wrap up, you were talking about outside consulting and moonlighting or other side gigs, and your perspective, I feel like, was very refreshing to hear about how when you as leadership or as the administration or the executive team, when you actually align yourselves with what makes that person feel whole, makes them feel complete. Can you talk about that? That there's something to everybody can win in that environment where you create the environment of autonomy for a provider to do life the way that they want to on their terms.
Yeah. So in my own career, one of the reasons that I wanted to move away from an RVU type of contractual model and really just to a base compensation with bonuses that are aligned with the incentives that everyone has. So as an executive, I share my incentives with my physician partners. We win together. So in that model, and again, no non-compete in that model. I don't, as an administrator, I really do not need to keep control of a physician. This is the problem, like with all labor, not just with physicians. We saw this through the pandemic, where we had people work from home, and then suddenly pandemic's over, and now we have to have butts back in seats. No one really can tell or have any evidence that being inside of an office creates better productivity. I would argue the same thing with RVUs. I don't think you really do measure true productivity. There are other ways to really understand, what you're getting, what you're doing for your patient population. So how do we then maximize a provider's life so that they are thriving? I believe that if a human is thriving, then they're going to put their best into all the things that they're doing. So if a physician, and I've in my career, most physicians, I don't want to say this is true for all of them, but for many physicians, having the opportunities to consult over here, be on the board over here, dabble in a little entrepreneurship over there, should all be on the table, right? Because compensation is not the only part of the puzzle here. We could pay you another $1 million a year or $500,000 a year, whatever it is, and you still would not be thriving because we haven't facilitated an environment where you've decided, and you've told the administrator, you've told us, look, here's what makes me thrive. I need to write a book. I need to have a podcast. I need to have my own entrepreneurial clinic over here on the side, and not have you down my neck about it.
Yeah.
Sure.
And by doing that, I'm really happy now when I come to work, and I'm more productive.
No, I agree with that. It's funny. I had that with my contract. They said, "What are your outside activities?" And I said, "Here they are." And they said, "Well, how much time a week do you spend on that?" I'm like, "That's none of your business."
None of your
And they're
damn
like-
business.
And they just kept diving into it. And I kind of said, "Listen, you know how much I make for you guys. That number's not going to change. You don't ask me how much I sleep. You don't ask me how much I sleep. You don't ask me how much time I play with my kids. Why do you care about my outside businesses?" That doesn't make sense, right? Like I should be able to do whatever I want outside. And that blows my mind. I think the last question here from Jimmy is that exact thing. As long as you're doing your job and doing your job at a high level, they should not care at all what you do outside of your job.
Yeah.
And I'll tell you, a really clear measurement of your success is your referrals.
Yeah.
You build up your referral pattern, patients love you. I don't care what you do, but if you're unhappy, you're miserable, and you're mean because you are irritable and depressed and unhappy, you won't have a referral pattern.
Yeah.
And what we want are physicians so if you really are the brand of an organization, then we should make you the best freaking brand possible, which means if you need color, if you need new clothes, I don't know what it takes, right? But we want that brand to shine. And that's different for everybody, but we should tap into that and make sure you're thriving.
I totally agree, Gary. Well, we're hitting up on the hour here. I think this has been excellent. Just one last time to go through it. If we didn't get through your question, I am sorry, but if you email it to team@docnation.com, we usually get to them all within the next 24, 48 hours. The other big thing you can do is sign up at DocNation, join the nation. Right now, there's not even a cost to hit the button. There's not a cost to even have the first meeting with either Justin or one of our other physician liaisons. You can have a meeting with us and see everything we do one-on-one, how we can help you one-on-one to your personal needs without any cost at all to you. I don't think it's when this is going to happen. I don't think doctors can keep getting beaten down like this. I mean, we just celebrated a 4.5% pay cut because it was going to be 10%. When I got that email, it said, hey, we did it. We got it down to 4.5%. That's when I said, this is when we really got to put the pedal to the metal and say this enough's enough. So I want to thank everyone for signing on. Gary, I want to thank you immensely. I try to it's hard to get someone with your background to help us out. So that's where I really want to thank you, because you are helping with all your insight. And thank you all for signing on. This is great. Next one's on February 28th. Keep a lookout in your email. Keep a lookout on our LinkedIn, on our Facebook. We're going just last one. Just don't turn into new admins yourself. Don't worry, it's not going to happen. It's not going to. I always tell people, if you see me running for politics, just know I'm going to blow it up from the inside out. Just don't trust anything I say until because it's Jimmy, a problem and I can't stand it. So
Jimmy, I've got answers for Jimmy. So Jimmy, let's talk offline. I've got answers for you here. I love what you're trying to do. There's no reason why you should be stopped. There's a pathway. So let's get this handled for you.
Yeah. And the last one here is there going to be a transcript? Yeah, we do have a YouTube channel. We haven't published the YouTube channel yet, but these are recorded. We will have these all on the YouTube channel. So that'll be on our website eventually here once we get enough of them on there to make it worthwhile for you guys. Thanks all. Gary, thank you very, very much.
Thank you.
Excellent. I hope everyone enjoyed it. We hope to hear you all soon. Join the nation, guys. It's going to be fun.